I know a lot of you were here last night, if not all. We had a great evening, lovely dinner, great company. I think it's great to continue developing this community of patients. We all seem to get on very well, and we share the journey, and that's so important and so helpful to us all. So today we're joined by the main clinicians on NETs in Ireland. Thank you all for coming. I'll introduce them individually as they're coming up to talk. So we'll have a few talks about the disease in Ireland, and we'll then break for tea and coffee, and we'll come back and we will have a question and answer session. So as I said last night, take this opportunity to ask your questions. It's probably the best part of the day, and it's always very interactive and really helpful to people. So if you don't want to ask a question and you prefer to have it asked by somebody, our committee members are around. So maybe if you could stand up the committee and just identify yourselves so people can ask you if you want to stand up, the committee members. So we have Tom, we have Margaret, we've Owen Mary. Don't know where everybody else is. So anyway, if you want to ask a question, or if you want a question asked on your behalf, just approach them and they can do that for you. So today is really about you, the patients, and getting as much from this as you can. So listen, take it all in, and we're all on the journey together. So with that, I want to hand over to Marcia, who is going to welcome us all to Galway.
Thanks, Mark.
If you talk into the microphone.
Talk into the microphone.
That'll take the next slide.
Perfect. I am so excited about being here today, and on behalf of Greg, Leonard and myself, we are so grateful to you, the committee, for having this event in Galway. We're very proud of Galway. We're very proud of our association with the national unit. I am going to wait for the slides, but while I'm waiting, I'll tell you a little bit about myself and what I do, I suppose. I'm an endocrinologist. Now, if anyone asks, the busiest doctors in the hospital are the endocrinologists. The oncologists love to tell you they're busy, but they haven't. Look. So we confuse people a little bit, because not only do we look after anything when there's a hormone deficiency or there's a hormone excess, and we also look after diabetes. And in some countries, that's separated completely. In Ireland, as it happens, we do both. And I think there's an advantage to that, and particularly in conditions like NETs, there's an advantage to that. Just a little bit about myself and my training. I trained here in Ireland, and like most people who want to become consultants and work in Ireland, we go away to another country and we pick up something extra to bring back to this country to help. So I went off after I qualified, and before I came to take up a position here in the year 2007, a long time ago, I went to London, to St. Bartholomew's Hospital in London, to do a fellowship in endocrine oncology. And that's where my love and appreciation for neuroendocrine tumors began. And then I was very lucky to come back to work as a consultant in Galway and to meet with Greg, who also had a huge interest in neuroendocrine tumors. And then over time, we've seen the country improve, and the people interested come together, and all the work that you've encouraged us to do to improve the services. So that's where I started off. My only claim to fame in life is that my mentor at the time became the Queen's physician. And although I never met the Queen, I like to think I was associated in some way. I'd have mountain time to see her. So this is where we work, Greg and I, in Galway University Hospital. As Greg said, we can't believe that the sun shone on the day they took the picture. Most of you know you need your umbrella in Galway. So Galway has probably the only level 4 hospital, and that's a hospital where most services are available in the area we serve. So if you look at the, I don't know, would you call it yellow or gold area there, we provide a tertiary referral endocrine service for everything that's in yellow. So we would see patients from the tip of the country there to where the yellow ends. On top of that, we provide an endocrine surgical service and as such a support endocrine service for the area in pink. Until very recently, there were very few endocrinologists, in fact one in the pink area, and so as such we looked after a lot and had the fortune to look after a lot of patients in that pink area and still do. So we look after a lot of patients. No, I'm going to go the wrong way. Sorry. Donal, yeah. Perfect. So we do that out of this building, and the bit that you don't see isn't any better than the bit you do see. But what I would like to tell you is inside, and I don't know if anybody here comes to that unit in the crowd, but I recognize one or two, but I would have to say, and maybe I'm biased, but I think the welcome in that building from everybody, from the people that help us keep it tidy to the people that meet you at reception, it's tiny. There's a huge weight to be seen. There's, I'm sure stress and frustration at times for people, but everybody in there hugely appreciate the patients and are very keen to meet people. What happens often with people who are coming back to us frequently, like patients with neuroendocrine tumours, we know them. We meet them. They're greeted at the counter by the receptionist, ask after family. It's part of there's a big family within the unit, and that family is extended to those who come and see us, particularly the people who come and see us often. I do clinics here on a Wednesday and a Thursday morning, and people know that they have walk-in rights in this clinic any Wednesday or any Thursday morning. So, that's this unit, and we're hoping it'll improve over time. Now, finally, oh Lord, let's take the next slide. So there's a spot prize later for anybody who can recognise our highlights in Galway. Galway is a really lovely city, and anybody later who can name all 6 places, there's a spot prize. So I'm really looking forward to the day, really looking forward to the questions and answers, and I'm very grateful to be allowed access to this group today. I'm hoping to learn a lot. Thank you.
Thank you, Marcia, for that. And I thought she was going to say the spot prize when we can get our technology working properly. Sorry about all the glitches that we've had. It's the rain in Galway. So with that, now I'm going to ask Greg Leonard to come and talk to us a little bit about nets and the different treatments available.
Welcome everyone to Galway. Thanks very much for coming, rain and all. I didn't see one bad picture there. All was sunny in Galway, Marcia, isn't that right? Yeah. Great, so let's see if this works.
Not working?
No. There's a few slides, so it might only take us 2 hours if this isn't working.
If you even want to talk.
I can just say next slide, do I?
Switched
Okay,
on.
so...
It's switched on.
Okay. Yeah. So this is the outline of events for the next 15 minutes, hopefully not 2 hours for my talk. And NET is really unique to most other cancers because a lot of other cancers are quite homogeneous, they're quite consistent. NET has such a variety. It's so different from the well-differentiated early stage to the very aggressive cancer. And every time we see a patient, we need to be looking for Batman, okay? We need to be looking at that one person and what their needs are. So this is where carcinoid came from, carcinoma-like, from this gentleman who basically founded it in Germany. And from here, everything has sprouted out where this is an individual cancer, not lumped in with bowel cancer or other cancers. And when I look at a patient to try and decide how we treat that patient, we look at the treatments we have, but specifically looking at the patient. We're treating the patient, we're not treating the cancer. So if we look at the cancer factors, what is the diagnosis first of all? So we have to get a biopsy. Where is it from? Is it from the pancreas? Is it from the bowel? What does it look like under the microscope? Is it very aggressive? Is it poorly differentiated? Is it high grade? These are some of the terms you'll hear. What is the differentiation? We then do these scans to see how much cancer there is. Is it just in the one organ or is it spread to other organs? And then the bit that Marcia comes in, this is when I pick up the phone and say, this thing is producing hormones. If it's not producing hormones, we kind of move on with some of our treatments. But if it's producing hormones, carcinoid syndrome, pancreas hormones, other things, then we need some help from the endocrinology people. So the treatments are first of all looking at local, can we get rid of this cancer? And that, for the most part, is surgery. But even if it's advanced, sometimes we can do surgery or other local treatments like ablation or embolization. And then the thing that I really do is the systemic treatment. And there's a term called systemic anti-cancer therapy. So sometimes when people think of treatment for cancer, it's chemotherapy, but there's so many more treatments that we have at our disposal. So probably the biggest factor that determines what we do when we're treating this is the grade of the tumor. So if anyone gets a diagnosis, one of the things you see is the grade, or the Ki-67, the proliferation rate. So if we look at grade 1, that's a well-differentiated, slow-growing tumor, usually less than 2 to 1%. And it kind of looks like the organ it started. So if it came from the pancreas, the cells are kind of similar to what it looked like when it was a normal pancreas cell before it started to turn bad. But as we move through the grades, grade 2 and grade 3, it becomes more ugly, it becomes more different. And when we get to the end, grade 3, it's what we call poorly differentiated. You can't really recognize where it started from, and it's a much more malignant, aggressive type tumor. And the treatment for grade 1 is totally different from the treatment for grade 3. And we have to determine that, and this is very important when we see the diagnosis, that we have those details, because that's what determines the treatments that we offer. So if you look at, I won't show too many curves hopefully, or won't go through them in detail, but if you look at these grades here, you can see in yellow, grade 1, grade 2, grade 3, and unfortunately the survival is very different for those grades. So grade 1 does well because it's a slow-growing tumor. Normally we look at hormone therapies. Grade 3 at the bottom, unfortunately, is a more aggressive type of cancer. Sometimes we're looking more at chemotherapies for that. So this table we see here, grade 1, grade 2, the mitotic count, that's when you're looking under the microscope and seeing how abnormal they look, how much turnover there is of the cells. And the Ki-67, that's a proliferation index, so it goes from 0 to 100. So once you get over 50%, these are very fast dividing cells, and it's almost like a type of lung cancer. We treat that one way. And then we have the slower growing ones, the grade 1, 2, and we treat those a different way. So grade really determines a lot of what we do and how we treat our patients with NETs. The location makes a difference, so even if you have the same grade, well differentiated, other factors similar, where the cancer came from does make a difference to prognosis as well. So when we look at that individual patient and we look at that individual cancer, we're looking at the location, the grade, the differentiation. So this would be a typical result we would get from the biopsy. We were told that you have small bland cells, there's minimal mitosis, this is a well-differentiated tumor, and then they do these stains, this kind of brown stuff, they inject stains onto the little slide that they've taken, and if they light up for these markers on something we call immunohistochemistry, synaptophysin, neuron-specific enolase, and chromogranin, this tells them this is a neuroendocrine tumor of the colon, it's not a colon cancer. So that's how they differentiate the two different diseases. So this is what we get from the pathologist, and then we have to go and stage the patient. So let's see where else the cancer is. So typically people will have a CT scan, we call that cross-sectional imaging, just to try and orientate yourself. This is like cutting through half of me there. The top is the front bit, and the back is the spine. You can see the kind of white stuff there. Don't have a pointer, I don't think. Is there a pointer? Okay. This side. Not sure. Anyway, that's the liver on the right-hand side, the gray stuff. Fantastic, thank you. So this is the front, this is the back, this is the liver here. This is normal kind of gray liver here, and these rounded things here are tumors. So the normal shade of gray is the normal, and then different colors. They can be blacker, they can be whiter. We now know these are the tumors here. This is the spine, this is the spleen over here. So this is the staging scan. So we might have a tumor that starts in the stomach. We do this cross-sectional imaging of the whole body, and that tells us where else the cancer is. We additionally like to do functional imaging. This is called an octreotide scan. This is the one we all have and had and started off with to see is there somatostatin receptors. Is this cancer spreading to other areas that we mightn't pick up on this scan? And is it somewhat functional? If it's functional, it'll light up. It's like injecting a dye of somatostatin into the body, and it lights up like a Christmas tree where the cancer is. So it's lighting up here, so we know there's a cancer in the liver there. A better scan than that, and what's available in Dublin, but it's also available to our patients, is a gallium PET scan. So this might be all you would see on the octreotide scan, maybe one little lesion on the liver, but in the same patient with a more sensitive test, the gallium PET, we're seeing a whole lot more disease. So we kind of need to do these scans to figure out the extent of disease. We might have thought of maybe surgery or something here, but obviously there's a lot more disease here. This is the liver here, this is the body. So the more of these tests we have to accurately determine where the cancer is, the better we can do the treatment. Sometimes we do an echo, an ultrasound of the heart for the functional tumors that Marcia might see. The valves can be thickened. So this is the tricuspid valve here. As these hormones are produced by the cancer, it causes fibrosis, inflammation of these valves, and they can get leaky and sticky. So sometimes for some patients we do this to assess whether there's going to be any cardiac issues down the line. So then on to the patient. So we figured out the diagnosis, the grade, the stage where the cancer is, but again, we're not treating the cancer, we're treating these people. So not everyone is Lance Armstrong who had brain surgery, chemo, and then fakes a few Tour de France's after that. Some patients are a little bit older. We have to factor in what Lance would get is different what this other person would get. People's perspectives on treatments are different, culturally, religious. We have to take into account that. What are people's goals? We may have goals for the cancer, but we're not making these decisions. Ultimately, it's a discussion with the patients. Not every patient is as fit as we would like them to be. I'm not sure if Donal O'Shea is here, but we have to make sure that we accommodate everything. We don't accommodate just Lance Armstrong. It's a rugby season at the moment. Does anyone know who this is? Probably the most famous French. Not Ramos, they're very current. Fullback now, no? Fullback for France, Serge Blanco, one of the most imaginative players for years. Anyone know anything else famous about him? What's that? I don't think so. I could be wrong. But so if he came into my clinic, I'm thinking, oh, super, he's really fit, we can do everything. He smoked about 40 to 60 cigarettes a day while he was playing and being one of the world's best players. So we have to look at all the comorbidities of these patients, the ones that aren't necessarily obvious from the outside. So sometimes if you have a low-grade tumor, well differentiated, we don't have to do treatment. This is an example of a tumor here. It forms this kind of scirrhous or fibrous reaction, starts to grab in the bowel sometimes. So this is, again, just to orientate ourselves, front, back. This is bowel along here with the white stuff in it is the contrast, and this is the tumor here with the kind of spokes grabbing in the bowel. And sometimes we don't need to do treatment. Not doing treatment is a treatment, and that's okay. So here's, for example, someone where no treatment was done for a number of years and things are fine. That's okay. Here's another hormone-producing cancer. This is an islet cell tumor, so sometimes the pancreas here can be producing hormone, insulin, just like you know diabetics take, and the sugars can be low. But with amazing endocrinologists who work so hard, like Marcia here, we can manage this by doing very little and not treating the cancer very aggressively, and that's okay. Sometimes we do want to do surgery, and of course if we want to remove the tumor, this is what we want to do. So this is an example of the tumor you saw earlier. You can see how it's kind of, this is the tumor, it's grabbing onto the bowel. So ultimately that is the curative approach, to remove the tumor, and that would be our goal if possible. And here, I'll keep on going back. But sometimes if we can't do surgery or we need to do something in addition to surgery, we have so many options. All of these options are available to us. These are all the licensed things for the most part. Some of these are unlicensed, but most of these are available to us. And the challenge is to figure out what of these we do for that individual patient. And every patient is different. It is a heterogeneous disease. So these are American guidelines, and you get a headache if you're looking at this or need glasses after a while. Very complicated, but at the end of the day, there's a few key drugs in here that we'll briefly look at. And again, you don't have to look at this chart. This isn't every patient. You're looking at this person with their comorbidities, their age, their wishes, their cancer. And it actually becomes a little bit more easy when we approach it that way. Now, some guys can figure it all out and they know all the answers, but as I say, everyone's different. So we're really trying to move away from chemotherapy for cancer to much more specific, bespoke, personalized precision medicine. And these are all these little targets that we're trying to figure out for every cancer, and not this blunderbuss approach. And the same for neuroendocrine. We started off with somatostatin analogs. You know about these, obviously. There's different types. This is some of the data. I promised I wouldn't show graphs as I show graphs here. And you can see we have this rule in oncology: if you can put your finger in the middle of the graphs, then it's a decent outcome. So you could definitely stick your finger in here between no treatment, placebo, and the treatment. So there's a real difference in getting somatostatin analogs for patients. It definitely improves the outcome for that cancer. And this is another trial by a different company. And can you stick your finger in here to separate those curves 100%? Now, you could say the overall survival might not be massively changed, but the progression-free survival, the short-term outcome of the cancer, is definitely changed by these medicines. And that's the overall survival. So here's another patient here with a tumor here. Very hard to see because sometimes these tumors are similar kind of grayish color, attenuation we call it, to the liver. But it didn't change with some somatostatin over, again, a period of time. So again, some of these less aggressive treatments or no treatments are very appropriate and work really well. And then we've moved on to biologic therapy, targeted therapy. So my namesake, Leonardo here, knew that blood vessel formation is imperative for the functioning of the body. And if you can start to kill some of those blood vessels, then you can improve cancer outcomes. So what does a cancer cell want to do to spread and get bigger? It sprouts out these blood vessels called neovascularization. If you can stop the blood vessel supply, you can basically cut off the supply for the nourishment for that cancer. So some of these drugs, anti-vascular endothelial growth factor drugs, try to stop the nourishment supply for the cancer and work very well. So again, the finger test, we can stick the finger in here between the curves of sunitinib, an anti-vascular medicine, versus the sugar pill again, and we can see that this has definitely improved outcomes. Another target, mammalian target of rapamycin, you get growth factor here. It sets off this genetic cascade of events that stimulates the cancer to grow. It spreads blood vessels, it prevents automatic suicide, it causes this dedifferentiation, all the things that cancer wants to do to spread and grow. This mTOR inhibitor stops that process. And this drug, everolimus, showed benefit in GI tumors and pancreas tumors and lung tumors. And again, you can see nice separation of the curves here. So a lot of very effective medicines that aren't blunderbuss. They're just specifically looking at a target that is in these cancers. What about chemotherapy? So we still have a role for blunderbuss therapy. We generally do chemotherapy for these more aggressive grade tumors that we talked about, the higher grade ones, the poorly differentiated, the grade 3. Those ones that I said are nasty and have a very high cell turnover and look ugly. We particularly do that for those ones. Sometimes we do it for some of the earlier stage tumors, if there's a lot of disease, if patients have a lot of symptoms, and there are different chemos that we can do for that. Some of you may have heard of temozolomide and capecitabine. This was kind of an American regimen. There was a European regimen. Some of you might have been aware of streptozotocin and fluorouracil. This is probably the recipe, the flavor of the month at the moment, because there was some nice studies, again, using the combination, showing a nice improvement in survival for this combination. is an older slide. The response rate was about 40% of people got a very decent shrinkage of their tumors with this. And this is for the slower growing tumors, not those faster ones that I said are more susceptible to chemotherapy. You're going to hear a little bit later about this incredible advance for neuroendocrine tumors called peptide receptor radionuclide therapy. So when we talk about treatment for cancer, which is like chemo or biologics, this is totally different. This is radiation that covers the whole body. And really, this started in NETs and is now moving into other cancer arenas like prostate cancer. And you're going to hear about it, but what it involves is injecting into the patient these little radioactive beads, effectively. They go around the body, and just like when we talked about the octreotide scan or the gallium PET lighting up with the Christmas tree, these little radioactive beads find those cancer cells with these receptors, these somatostatin receptors. They stick to them and then basically radiate them and kill them. So this has shown amazing results for this tumor. When we have survival curves for colon cancer, breast cancer, we have these things called hazard ratios, the hazard of dying, the likelihood of getting an improved outcome. Usually they're about 0.7, 0.8, meaning we're improving outcomes by like 20% or something. The hazard ratios for these are like 0.3, 0.2, and they're incredibly responsive, incredibly impactful, and a whole new treatment armamentarium for NET patients. This was such a big deal, it made the New England Journal of Medicine. People will know that if it's a really big study, if it's a really important study in the medical community, whether it's cardiology or respiratory, it makes this journal. So that's a big deal. This is a big deal, PRRT, and you'll hear Hussein talk about this later. So again, we have all these treatments. We have different heterogeneous patients. We need to personalize this for every individual person. So if we have a gastrointestinal NET, for example, all those different treatments that we've discussed, we could start off with somatostatin analogs. If they light up like the Christmas tree, we could maybe use this PRRT treatment. If they have a lot of symptoms in the liver, maybe we just deal with the symptoms in addition to Marcia's hormones. We can blast them with maybe embolization, and we have these biologics. So again, for every individual patient, not just the cancer, we have treatments. If it's pancreas, we have even more of these treatments, more biologics. Chemotherapy seems to work better in the pancreas group than in the gastrointestinal group. So again, bespoke medicine for that individual cancer. If the somatostatin receptors, if it doesn't light up like a Christmas tree, that's okay. We have other treatments. What is the optimal sequence of all of these treatments? We don't really know, and to a certain extent, does it really matter? What's important is we try and get all of these active treatments in at some point in the disease course. So that is more important than finding the best one up front. In general, if it's a low grade, slower growing, grade 1, not a lot of disease, we could do nothing. We could give somatostatin analogs, or some of these biologics that don't cause a huge amount of shrinkage, but keep things nice and steady for a long time. So sometimes less is more. If it's a higher grade, faster growing, ugly, grade 3 type tumor, then we have these options of chemotherapy, or now in Ireland, PRRT. We have a fantastic group. It's a very small group. You see most of them here, and there are others, obviously. We have the National Neuroendocrine Tumor Meeting in Vincent's. We all get together virtually. COVID has really helped us work where we don't all have to be sitting in the same room. And I can pick up the phone and ring Mark or Hussein. He mightn't agree with me, but we can ask them what they would do. So how we decide this bespoke treatment is this neuroendocrine meeting to get that opinion. Where are we going in the future? What else can we do? Well, we're trying to move away from treating pancreas NETs or gastric NETs. We're trying to figure out what is the genetics of each of those mutations, of those cancers. So we're less interested in the location, the origin, and trying to figure out what the mutations are. Because every tumor is unique, just like every patient is unique. So for other cancers now, we're starting to approve immunotherapy for tumors with MSI, which is a signal of sensitivity to immune therapy. It doesn't matter if you're breast cancer or colon cancer or NETs or whatever, this drug should work. So this is a unique thing now where we're treating a mutation, not the location of the tumor. And this is a huge advance, and I think this will continue to evolve. We know that for every tumor or piece of tumor, there's different mutations depending on where you biopsy it. So if you have a neuroendocrine tumor and I biopsy it in the tummy, you might have some set of mutations. If I biopsy it in the liver, you might have a different set of mutations. And now we know that maybe we can even get these mutations by getting peripheral blood. We call these liquid biopsies. We just take a blood sample, it measures the shedding of this tumor, it sheds little pieces of tumor into the blood. We can measure the amount of that in the blood, and we can measure the mutations that are within that. So now we potentially can do these things as the cancer evolves. So it's a dynamic test and provides us with a lot of information. It's not really prime time yet, and it's more for the poorly differentiated tumors, but again, this is where we're heading in the future. But don't forget when all of this is finished. So loads of treatments, loads of interaction with doctors and hospitals, but what happens when we leave that system? Perhaps we have surgery for cancer and now we're finished with that system. We can't forget about those patients who are now out in the community. They've been so used to coming in every 3 weeks for their injections or their drips, and now they're out there and sometimes they can get a little bit lost. We know that we don't think about cancer survivorship as much as we do the cancer treatments. So we need to continue the care of cancer patients, neuroendocrine and others, through the full continuum of their life, not just when they're on the treatment, and importantly, when they're finished treatment and, please God, cured. You've survived cancer. What comes next? Who's holding the babies? What are the social circumstances? What is the impact? Does the person have neuropathy? Do they have other things that the cancer treatment or cancer has brought about? Is it affecting their lives? So we have to make sure we look at quality of life. It's not just about quantity of life and curing or getting someone living as long as we possibly can. We absolutely want that, but we have to look at quality of life. So what is wellness? Because that's what we're looking for. Wellness is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So just because we have cured the cancer, the patient may not be well. We need to look at all of that. You treat a disease, you win, you lose. You treat a person, I guarantee you, you'll win no matter what the outcome. Very famous philosopher. Patch Adams, Robin Williams in that film. So remember, for everyone in this group, we're not treating the cancer, we're treating the individual. And we want them to be well, irrespective of the cancer outcome. Exercise is important to improve people's well-being, to improve cancer outcomes for sure, to improve their quality of life. The guidelines for exercise for me are the same for patients who have cancer, and if they're able to do that, we want them to continue to do that. And we have a brilliant setup at Cancer Care West, and Fionnuala's here from the Irish Cancer Society, and Fionnuala can show you where to go, signpost you to get all of these other services in addition to the chemos, nutritional support, psychological support, counselling, exercise programs. All of these are important, particularly in the survivorship phase. So how do we figure it all out? How do we optimize the continuum of care? Some of these people are here in front of me. This is the HACA here. Dermot O'Toole is he's running the HACA, I think, is he? So we need all of these people to come together. And honestly, that's what the Vincent's National Net MDM is. If I have a challenging scenario, I'll pick up the phone. Yesterday morning, Friday morning, I was on video with the group you see here in front discussing patients from Galway. What do I do with this patient? What collectively do we think is the best thing to do for our patient? And of course, we all wouldn't be here today, and thank you all for coming, if it wasn't for one person who I know we're going to tribute later. He has had a huge impact to the quantity of life, the quality of life of NET patients, and he won't be forgotten. So it is Christmas. Don't know if you're down in Eyre Square, it looks pretty cool. Take a visit while you're doing Marcia's sites there. So what would I like for Christmas? I would like to be able to provide that bespoke treatment. I'd like to have a gallium PET scan in my back pocket. There's new medicines coming through like cabozantinib, a really exciting new TKI for neuroendocrine tumors. I'd like to be able to get all those medicines and use them and give the bespoke treatment for my patients. In case you think medical oncology has a cancer build in Galway, we don't. Radiation has a cancer centre, we don't. We need a cancer centre. We work in a little porta cabin smaller than Marcia's. And I want tickets for Ireland matches. I love going to Ireland matches. We love going. So if anyone has tickets, great. Thank you very much. Thank you.
Thank you, Greg. I don't know about you, but I thought that was fascinating and really well put together and well explained for us as patients. Really excellent. So with that, I'm going to invite Mark Doherty to come up now and talk to us about treatment pathways or patient pathways. And just to say, Mark's son, I think, is his birthday today, and he has to head back to a birthday party in Wicklow by 1 o'clock. So he'll be leaving us shortly after this. So, but thanks for coming.
Thanks, Mark. Okay, good morning. Thanks very much for the invitation. I'm happy to be here to speak to you all. So lots of familiar faces, people I know, people we've met through the service. And I sort of wanted to, I sort of wanted to pitch this a little bit in terms of people who are maybe less familiar with the service, or, you know, even if you've been interacting with the net service for many years, hopefully I'll give you a peek behind the curtain, because sometimes the hospital and a medical system can look a bit monolithic, you know, from the outside. It's a big granite building, and you might see one person when you go through the door, but actually there's a huge amount of work that goes on behind the scenes to coordinate everything and make sure that when we're sitting in front of our patients, that we have all the tools at our disposal to be able to offer those best treatments. So all of those things that Greg talked about, to be able to make that decision in real time with the person in front of us, and to be able to move that along in a way that is efficient and produces the best possible outcomes. So sorry, I'm just going to set myself a timer here so that I don't go over time. So I'm just going to outline broadly what the structure is looking after patients with neuroendocrine tumours on a national basis, and more specifically locally in St. Vincent's University Hospital, how we provide care through the MDM and the NET clinic, and just maybe some hints and tips in how to access care and how we coordinate services across the group. So, I mean, it's an absolute bombshell in the middle of anybody's life to be diagnosed with a neuroendocrine tumor, and particularly if it's a diagnosis that's made outside of, you know, the group that the medical team that are here today, you know, perhaps a surgeon or a medical physician in another hospital makes a diagnosis of a neuroendocrine tumor, and they say, we found this thing, you know, it's a very rare tumor, we don't really know what to do with it, but we'll send you to Vincent's, or we'll send you to Galway, or we'll send you to Cork. And maybe they don't have all the answers, maybe they can't give a full set of information. And also it's a little bit, I suppose, you know, it can feel a bit isolating that you're sort of left without that information or that guidance of how things are going to proceed. And one of the things that I always say, I particularly say to our trainees in oncology, is that when the patient sits down with us, we should be able to give all of the information that they need, as much as we have in our power, and to be able to dispel as much of the uncertainty, to be able to dispel as much of the anxiety about results, about a plan, about what's going to happen, and to be able to set things up to move forward, to have a plan that moves into the future, that can provide some degree of certainty, some degree of hope, and a feeling of reassurance, a feeling of being sort of held around the shoulder and guided forward. So as I said, like we often get referrals into the NET service through by email, by letter, from surgeons, from gastroenterologists, from physicians all around the country. And we see hundreds of new patients every year through the NET service in St. Vincent's Hospital from all of these possible avenues. So it was interesting last night. We had a discussion with one of the endocrinology team from Belfast who runs the NET service. And actually in pathology in Northern Ireland, I don't know if this is across the NHS in the UK, but it's certainly in Northern Ireland. Now, whenever the pathologist reports a neuroendocrine tumour, they have a line on the end of it saying that this patient should be referred to the neuroendocrine tumour service in Belfast. And so I don't think that there's anything similar to that in Ireland, but maybe it's something we should be looking at and rolling out through the pathology service, because I think that would help to integrate it and raise awareness. So we we try our best to raise awareness across the medical community and across GPs in terms of the service that we offer and how to send patients in. But something like that would be structured could help, I think, as well. Sometimes we get referrals in through GPs, a little less common, because often these tumours are diagnosed through a hospital, through CT scans, and through biopsies, through colonoscopy, or through an operation. But sometimes we do get referrals in from GP. Sometimes it's because patients go to see their GP and they tell them they've been diagnosed with this, and the GP says, oh, hey, you should be going to Vincent's. Or it's because perhaps, and increasingly, patients who are moving to Ireland from abroad, perhaps with the history of a neuroendocrine tumour, who have been on treatment for neuroendocrine tumour, and they come with a stack of documents from their home country, and the GP will flick through it all and say, all right, I'll send in the referral. And then some patients find out through this kind of forum, through Net Patient Network, and through, the late Tommie did an awful lot of work in guiding people through the correct avenues to access care, and through word of mouth, through talking to other patients or family members or meeting somebody, and then they will sometimes they contact us directly, and we say, listen, we're happy to see you, but we need the documents, we need the information, we need a referral in. So the service at St. Vincent's Hospital is designed around the neuroendocrine tumour MDM, which is our multidisciplinary team meeting, which happens every second Friday morning. And that has been, I suppose, shaped and guided by ENETS, the European Neuroendocrine Tumour Society, who ratified us as a centre of excellence in 2016. And who have a very stringent set of criteria in terms of the quality of that service and how it should be run. And their model is very much that it should be run through a multidisciplinary team meeting structure. And so at that multidisciplinary team meeting, we have a number of medical specialties in terms of expert pathology, expert radiology, we have medical oncology, we have endocrinology, gastroenterology, we have surgeons, we also have specialist nurses across those various specialties, and we have nuclear medicine and PRRT representation. We've since the advent of PRRT, and I'm not going to talk too much about that because I don't want to steal Hussein's thunder, but we've set up a separate PRRT MDT where there's a slightly more focused group of specialists to look at the specific issues around administering PRRT and selecting correct patients for PRRT. And we then interface, as Greg said, we interface with the centres in Cork and with Galway, who have their own structures for discussing patients and for coordinating the care through that. And this was a sort of a candid photo that I surreptitiously took yesterday morning at the NET MDT. So sorry, Hussein, if I haven't caught your best side there. So what you could see on this, do we have there's a pointer here somewhere, is there? Oh, I see it. So this is where I was sitting here. This is my coffee cup in front of me. This is our patient list. So I counted out yesterday, there were 14 new patients for discussion. And we also had about 20 patients who were on follow-up. So what happens is that patients who are on surveillance or on treatment, if they have a scan, we generally put that back through the MDT for assessment and for discussion. And up here in the corner, you can just see the top of her head, Nicola Hughes, who's one of our NET radiologists, so an expert radiologist who specialises in neuroendocrine tumours. And he's turning the wrong way. This is Neil Swan here, who's one of our expert pathologists, really our lead pathologist in terms of neuroendocrine tumours. And so when, this is Barra here, who's our NET fellow, and Lisa here. And so Lisa and Barra have all the patient's charts here. And as we go through the list, they open the charts, they have the referral letters in, they have the documentation, they have the last letters from the clinic if it's somebody who's been seen. As the patients are referred in, we collect all the information, so we get the scans. Vincent's is a little bit outside of the national image system, so we often have to have the scans uploaded onto our system. So we get the scans uploaded and reviewed by our net radiologist. We get the pathology in, and that will be displayed on this screen, and that's reviewed by our pathologist. And often, I mean, sometimes most of the time the scans tend not to change very much, but we can sometimes, by giving the radiologist a little bit extra clinical information, we can change their interpretation of a scan by saying, listen, you know, you said there's nothing in that area, but I could feel something there, or a patient has a pain there. Can we just look at that again? And sometimes with that additional clinical information, it can help to get a better read on the scan. Sometimes also by looking for the specific features of neuroendocrine tumor, the way that they behave after the contrast that's administered for a scan, or the way that they look from one scan to another, we can get a little bit more information that comes from the sort of basic radiology report. The pathology is often the sort of key thing, and sometimes a pathology report, if it's not read, you know, in an external hospital, if it's not read by someone who's very familiar with looking at a neuroendocrine tumor under the microscope, sometimes we can get a little bit more information out of it when it's reviewed at our center. And you know, all of these measurements, so as Greg talked about, the grading, how aggressive it looks under the microscope, excuse me, and the Ki-67, so counting how many of those cells look like they're dividing or growing. With somebody who, like Neil, is looking at dozens of these cases every week, he has developed a really strong skill base in order to be able to give the best results out of that pathology information. So all of this is handled through our MDT coordinators. Jenny Cross and Lisa Cullen do like an enormous amount of work behind the scenes to arrange everything, to get everything into this sort of crucial time point when we can discuss it, when we have all the clinical specialists in the room and the diagnostic specialists in the room. And what can happen then is we can have a proper discussion about how is the person, what does their scan look like, what did we see on the biopsy, what's the best treatment approach, or how do we plan things for that person from here. So following that MDT on Friday morning, we go downstairs to the NET clinic, and we run a multidisciplinary NET clinic where we have generally the senior NET consultants, so Professor O'Toole, Professor O'Shea, Dr. Almeamar, and myself. We then are accompanied by Lisa Cullen, our clinical nurse specialist, and our NET fellow. We're very fortunate to have Barra working with us this year, who's excellent. We then can sort of bring in other specialists as necessary. So sometimes if there's a decision to be made for surgery, now the surgeons tend to run their clinics parallel at the same time as ours. So often we'll say, we think you need an operation, go down the corridor there and see Professor Gallagher, but sometimes the surgeons will come and see the person in the NET clinic as well. We run a combination of in-person and virtual appointments. So the other, I suppose, advent following COVID, as Greg said, not only do we now have that link where, particularly through the PRRT, MDT, we can discuss patients across the country, but we can also talk to patients through the clinic, which was not a structure that was really present in any real way prior to COVID. You know, outpatient clinics and health services in general tend to be slow ships to turn, but things had to innovate quickly during COVID, and so we brought in these virtual clinic appointments. And I suppose if there's a long or complicated discussion, or if there's bad news to be given, or if we have to plan a new treatment, or if there's some sort of serious discussion to be had, it's better to do that in person. But for a lot of the other stuff, if we're talking about scan reports, or if we're talking about scan reports that look okay, or if we're talking about just a checkup to see maybe someone started on somatostatin analog injections, I'll often book them for a phone call after 6 weeks just to check in. How are you getting on? Have you had any trouble with bowels or anything like that? So we can use those for those virtual appointments or blood test results or whatever, the sort of more straightforward stuff. And that's a lot more convenient for patients. They don't have to come in and sit in the waiting room. They can live their life, and we can contact them in a way that's more appropriate for that. Usually, the appointments for the clinics are made after discussion of the multidisciplinary team meeting, after the scans or pathology. And I could certainly understand from a patient perspective how that could be frustrating, where it could be, I've had my scan, why do I have to wait 2 or 3 weeks to come and get the results of it? Or you've had the referral for 2 weeks, why haven't I got in to see the doctor? And the reason is that with the amount of information that we have to collect in order to make the right decision, in order to pick the best of those treatments that Greg talked through, the best way, the very best way to do it, and it's not just us saying it, this is ENETS, the European guys, is that it comes through that MDM discussion. And then from the clinic, we tend to refer out to other services. And so I'll just talk to you briefly about what some of those other services look like. So I'm a medical oncologist. I probably should have introduced myself. I'm a medical oncologist for those who haven't met me before. And so I, like Greg, we deal in anti-cancer therapies. Most commonly, for most cancers, we prescribe chemotherapy. It's less common, I suppose, in neuroendocrine tumors. And I see patients in the NET clinic. So I'm always slightly hesitant about introducing myself in the NET clinic as a medical oncologist, because I think it could give people a bit of a fright, you know, if they're kind of just walking into the Professor O'Toole name over the clinic. But just because you see me in the clinic doesn't mean anything. Don't read too much into it. We see patients all together in the clinic. But our service, so outside of the NET service and the NET clinic that I participate in, I'm part of the medical oncology service at St. Vincent's University Hospital. So we have 20 inpatient beds shared with hematology. Those are our beds for admission, generally for chemotherapy. We have separate medical oncology outpatient clinics, which are run in the Nutley wing in St. Vincent's. So some people come by dint of referral pathways. Some people come see me directly in that clinic first, but usually if it's a neuroendocrine tumor, unless they're on treatment with me, unless they're on a targeted therapy or chemotherapy or something like that, I'll ask them to come back through the NET clinic, because that's the sort of the most well-established pathway. But you may meet me in the oncology clinic if you're on a treatment. We also have an oncology day ward where we have treatment chairs. We have oncology nurses who administer treatment there, be it chemotherapy, be it targeted therapy, be it supportive medications. And we have several specialist nursing services associated with the medical oncology service. So we have clinical nurse specialists in oncology. We also have oral anti-cancer therapy programs where we can monitor, sometimes remotely, patients who are on targeted therapies. And we have triage service for patients on treatment. So if you're on a targeted therapy or chemotherapy under my care, you can call into this service, and if you're feeling unwell, either get advice or get access to a service to come in and get bloods checked or be admitted to the hospital. The other service that we most commonly, I suppose, interface with is the surgical service, predominantly the HPB surgery service at St. Vincent's. And we have 5 full-time HPB surgeons, and we generally have at least 2 of them come to the MDT every fortnight. We have specialist HPB nursing services, so the nurses also come to the multidisciplinary team meeting. They have surgical beds. We have state-of-the-art operating theatres with robot-assisted surgery where it's appropriate. They can use these fancy robots to help to reduce complications in terms of the operation. And Vincent's is designated as the National Centre for Pancreas Cancer Surgery, and that's sort of flowed on to the neuroendocrine tumour service. So most of the time, if people are being referred for surgery for neuroendocrine tumour, it's to one of those HPB surgeons. Justin Gagan was our point man until he retired. We now rely predominantly on all of the others, I suppose, really. Tom Gallagher, Fiona Hand, Demir Hoti, Donal Maguire and Tony Stafford. So those are generally the surgeons that work with us. I'm not going to talk too much about the PRRT service because Hussein's going to give you a long description of that. This was a photo taken at the opening of the service where Tommie was there for that wonderful ceremony. And it's a separate service. It's a real boon to have this now in Ireland, and to have it sort of embedded in the service and to help to provide that continuity of care where in times past it was another group of doctors and nurses that would have had to pick up that treatment abroad, whereas now we can sort of encompass it within our own service. So I suppose just a few tips in terms of how to engage with the service. You know, I mean, like I said to you, it can feel a bit monolithic from the outside. Lisa's at the back of the room here. She has an email that's always open. You can phone in. You could go see your GP, and they'll often send. We tend to get health mail referrals in. So the GP will say, "I saw Mary. She's not feeling well. Can you bring forward her appointment?" And we react to those through the Net Clinic. I've mentioned to you about some of those avenues. If you're on treatment under the medical oncology service, there's different avenues of access in terms of advice and support there. Because in general, if you're on chemotherapy, if you're on targeted therapy, you may be more likely to need some of those support services more frequently than, for example, if scans are all clear and you're just on surveillance, or perhaps if you're on somatostatin analogs and things have been stable for a long time. I always advise people to bring someone, if you have someone to bring along to the clinic appointments, because 4 years are better than 2, and it can be very difficult when you're getting a huge blast of information, all of those things that I talked to you about in terms of the detail that goes into the MDT discussion and making that diagnosis and making that treatment decision. We then kind of blast all that at the patient when they're sitting in front of us, right? So having somebody else there to take notes, to help ask questions, and then to debrief afterwards to say, what did he say when we asked him about that, is really helpful. Obviously not for the first clinic appointments, but for any clinic appointment, it's a good idea to try and think ahead in the couple of weeks coming up to the clinic. What questions do I have? What are my priorities out of this? What do I want to know? Where do we think things are going from here? And the hospitals are incredibly complex, and I hope I've given you a slight bit of flavour for that. But there's a huge number of moving parts, and they're incredibly busy, and we try to have everything line up in the way that is best, that is appropriate, that the scan happens, the MDT happens, the clinic happens, the treatment happens, the follow-up, and all of those things happen in the right way at the right time. Sometimes they don't. And so if you get appointments that don't seem to add up, check in with us. If you've got a clinic 1 week and a scan the next week, that's not the right way for that to go. If you've been told you're going to get a scan, if you've been told that you're going to be coming on for treatment and you haven't heard anything after a week or two, check in with us. We don't mind, and we'll tell you if everything's fine. You just got to wait, or that was missed. There wasn't a letter went out, or the text message, or whatever, and we can address that in a timely fashion. So I'll finish there just to say, again, that I hope I've given you some flavour. We've got lots of moving parts, and we rely on a lot of intersecting clinical services. So the net service, that clinic, is sort of the core, but there's a lot of other bits that move around it. We have a national service that's offered primarily through St Vincent's, through Galway and through Cork, but we also rely on colleagues in other cancer centres. So for example, sometimes patients, if they're getting chemotherapy or targeted therapy, they might be monitored through a cancer centre in Waterford, in Limerick, in Letterkenny, whatever's more convenient to save people coming up and down to me in Vincent's all the time. And obviously the whole point of this, and it's massively beneficial to have it, is the education on neuroendocrine tumours, as well as education on the structure of the service, which is what I've been trying to do for the last 20 minutes. I think it really helps. It helps to reduce any delays in your treatment, improves efficiency, and also dispel some any fear or distress or worry about where am I in this system. So I'll end there. Thank you.
So thanks to Mark, and he has to head off now, but thank you very, very much. That was a really great overview of what happens. And we as patients, we go to our consultations, we see one doctor maybe, and we don't really, I think, appreciate what's going on in behind. And I know a lot of people have said about, oh, the scan was done, and why can't you tell me what's happening? But I think we got a good answer there, that the MDT is happening, and all those experts are giving their input into what the decision for us going forward is best for us. And we as Net Patient Network and INCA and the global organization for neuroendocrine cancer patients are always pushing MDT is the way to treat this disease. It needs to have multiple specialist inputs into deciding what is best for us going forward. So I suppose have that in mind when you're saying, why didn't I hear about my scan? And I think also to have control of your own disease, and I think Mark put it very well there, if you're getting appointments that are out of sync and that, then we are responsible ourselves to try and make sure that we're getting the right treatment. So learn about the disease and speak up then if things aren't right. And I think Lisa and Jerry in Vincent's and the equivalent, I'm sure, in Galway and Cork are available to us to query that and try and get the sequences right. So I'm going to say that we will have tea and coffee shortly. There is lunch after this. We're asked by the hotel to specify what our options are, so we get a form sent around if you can please tick what you want for lunch. So that'll have to be pre-done. Everybody's welcome to stay for lunch if you want. And the next part now is Hussein Almeamar from St. Vincent's is going to talk to us about PRRT, this wonderful new treatment that's now available in Dublin.
Okay, thank you. Thank you so much, Mark, and thanks all for being here today, and thanks for organizing this meeting here in Galway. Thanks for Greg and Marcia. We had an excellent talks so far. I'll talk about the PRRT more from service development and more from the logistic point of view and what to expect if you are to get a PRRT in Dublin. Greg explained to you why PRRT, how it works, and why it's important, and the data showing a benefit of PRRT. So I'll not talk about that. And these are my disclosures. I would like to start by showing you the evolution of the national net service in Ireland. And Mark did talk about how the service work and the MDT and the clinic, etc. But I'll show you a bit of a timeline. So it started back when Donal O'Shea was seeing a net patient as part of the endocrine clinic in the early day when the net service wasn't yet recognized as a national service in Ireland. And this eventually led to the development of the net patient network and recruitment of Dermot O'Toole, who's unfortunately couldn't make it today. And this eventually led to the appointment of Dermot as a clinical lead and establish then the center in St. Vincent as a national NES center. And appointment, of course, of Lisa Collin as a nurse specialist and the net MDT, and together with two centers in Cork, with Derek and Christopher leading the team, and in Galway with Marcia and Greg. And this was the start then in 2013, 2014. Later, as Mark showed you, we got accredited as an ENET center as part of the European group as a center of excellence. And what does that mean? That means that we have to stick to standards, we have to submit data, so it was a very important milestone. Later then in 2019, we started to have a gallium data PET service in Vincent, and so of course, it was a very important milestone. Then in 2021, we got another accreditation with the European Rare Disease Network with the cancer group, the Eurocan, and that was important as well. With regard to the ENETs, the accreditation, how it works is every 5 years, you need to get, there was an audit and we were re-accredited, and the feedback was very good. And this will give assurance that we are doing the right thing. And then eventually, end of last year, beginning of this year, we started to have finally the PRRT service in Dublin. So what next? It's been 15 years of a lot of work, of a lot of people involved. Mark mentioned a lot, for example, of surgeons that were involved, the radiologist, is a big team, pathologist. What next then? We need to focus on clinical trials. As Greg explained to you, that there are a lot of new treatments that are still investigational. So we can't prescribe this treatment, and to give our Irish patient early access to this treatment, we need to set up clinical trial. So this option will be available for carefully selected few patients. And also, as part of the European group, we are part of the European registry and database now. And thanks to you attending to the NET clinic in Dublin, we always ask for consent to be on that. What does that mean? The Irish patient will be part of the big European study, and this is important. So we'll focus on that next. I would like to highlight in picture a few milestones. This is when Dermot got appointed as a clinical lead more than around 10 years ago. And this is when we got re-accredited with ENETS as a Center of Excellence. Mark did show this, the second picture here. This is in March when we officially launched the PRRT service. You can see, as Mark showed you, a lot of people attended this event, including the late Tommie Gorman. This was taken in the PRRT room. I'll show you some pictures later. This is just to show you our numbers in the last couple of years are almost doubling. This year is just until September. So how many patients discussed at the NET MDT from around 500 in 2018 to almost 1,000. So the numbers are increasing over the years. With regard to the PRRT service, before establishing the center in Dublin, as some of you in this room, we were using the treatment abroad scheme and to send patients abroad to Uppsala, to the UK, like in the Royal Free, to Rotterdam. Some of you went there. And we did look at that, we did audit that, and we showed that the numbers were increasing. And with regard to the benefit of the treatment, it was similar to the big data that Greg showed earlier. So this highlighted the importance of establishing a service here in Ireland. Who are we? The PRRT service is a multidisciplinary team. There are radiologists involved who are not here with us today. Nicola Hughes, I think Mark showed a picture earlier. Have Mathilde Colombi. They lead the radiologist and Stephen Skehan team, the NET specialists, our NET specialist consultants. We have medical physics involved because this is a radiation treatment. And we have Jackie, Anne. They lead the team there in Vincent's to look after PRRT patient. And we appointed PRRT nurses. So we have Hilary, who's here. Can you stand, Hilary? And Anna Priya. This is Anna Priya. And they'll be looking after you when you come to the PRRT service. And there are other, of course, like MDT coordinators and other specialties involved as well in the service. Of course, setting up a service involves setting up protocols and pathways and how to look after patients from when they are referred, when they see in the clinic, when they get the treatment, and if some complication happen, etc. So it's all in place, and this is all accredited by the National Cancer Control Program. If you Google PRRT in Ireland, this will be the first what will come. So it's all available now as part of the HSC website, where you could get all the information you need about the PRRT service in Ireland, including information leaflet, etc. So I would encourage you to use this source rather than other sources if you are looking for PRRT information. Of course, when we set up a new service, there are staff training. So with regard to the PRRT team, we went to different centers in the UK, and thanks for their support. And also we did training for the other staff in the hospital, because there'll be patients coming in the hospital, so nurses, other doctors from other team, they need to know what is this new PRRT service. So these all, they were the early steps before starting the service. With regard to facility, this is the treatment room. We have facility to deliver 2 treatments in 1 day, and some of you already had the treatment or still having treatment cycles, and you can see some shielding here with lead because this is radiation. You'll be sitting in the chair for a couple of hours getting the treatment as a drip, and you'll come a day before for admission. So we have 2 separate admission rooms where you'll have your own bed, your own bathroom, and then you'll go to the treatment room, finish the treatment, go back to your own admission room, then to be monitored for at least 1 night, and then there'll be a couple of scans just to make sure the treatment reached the right target, right? So, of course, setting up a new service, each one of these resulted in a little bit of delay, but we have the facilities finally up and running when we started the service. With regard to referral, Mark did explain a little bit about that. So we set up the picture Mark showed earlier about the net MDT. We use the same room to have a separated PRRT MDT. How could you be referred to this MDT if you are a patient? This comes directly from the net MDT if you are a patient who are linked with the national net MDT. If you are attending the clinic in Cork or Galway with Greg or with Derek Power, who's not with us today, you can be directly referred to the national PRRT MDT because Greg and Derek, they are part of the PRRT MDT group. If you attend other oncologists or specialists, you could still be referred, of course, to the PRRT service, but it has to go through the net MDT first, then you'll be discussed at the PRRT MDT. Just briefly about our protocol. So each patient, we can't deliver the treatment. You have to be discussed at the MDT first. And I didn't mention here on the slide, before the MDT, as Greg showed you earlier, you'd have to have a gallium scan, because the gallium scan, as Greg mentioned, is not only showing you the site of disease, it shows you a signal that means PRRT is the right treatment for you. So you'll have your case discussed at the PRRT MDT, and if the decision is made that PRRT is the right treatment for you, then you'll be seen in the PRRT clinic. This is a new clinic we set up where the net consultant will sit down with the PRRT nurses to go through everything and to see if you have any other issues before starting the treatment, to talk about the injections, because as some of you who had PRRT know that while getting PRRT, you still continue on your monthly injection. Just the timing need to be adjusted because they work on the same targets. Then you'll be seen in the nuclear medicine department with the radiologist. This is with Nicola and Mathilde and medical physics. So Jackie and Anne to talk more about radiation and radiation precaution, the radiation treatment. So whenever you get a treatment cycle, then you'd have to stick to some precaution in terms of contact with other people and isolation for around 3 weeks, and this sometimes tailored accordingly when you finish the treatment as they measure the radiation from your body. So this all will be done before your first treatment cycle. And the standard protocol, we give 4 cycles. They are around 8 to 12 weeks apart. But again, this sometimes could be tailored according to patients. In each cycle, when you come, as I said, you'll be admitted, and medical admission, and then before admission, the room needs to be prepared by our nurses, medical physics, and then you'll go to the treatment room where you get the treatment, and you'll have the scan then. After the first cycle, you need to have 3 scans, 1 day, 3 days, and 7 days after the treatment. But then in the subsequent cycles, 2 to 4, it will be only a scan the next day, then you could go home. Then obviously when you go home, there are a couple of checks. The net consultant needs to see you to make sure everything's okay, give you a prescription for some medication that you need to take orally, going home, and the physics and the nurses will be with you to check the radiation again, and sometime we take your clothes, check radiation, and there are a couple of steps need to be done before you could finally go home. Before each treatment cycle, you need to be seen in the PRRT clinic, and we could do this virtually sometime if you live far away. After 2 treatment cycles, we need to repeat your CT or MRI or both of them accordingly, and after you finish the 4th cycle. Sometime if the scan report highlights some issue, we need to discuss the case again at the MDT. And this is a lot of commitment, but you'd have to have bloods done every 2 weeks. And this is usually done, could be done by your GP or could be done by the local hospital. And this will be monitored closely by us. What will happen if you have some trouble? You go home, then you'd have some trouble. You might have pain, you might be sick and well. So we have the PRRT nurses that you just met. They're available Monday to Friday to be contacted by email, by phone. And obviously, we always advise you, if you are really unwell, not to wait just to attend the emergency department. Sometimes we coordinate with GP and local oncologists if you live far away. For example, we had a patient who was unwell, live in Cork, unable to attend to Dublin. So I asked Derek, for example, to see in the clinic, and we coordinated together just to make life easier, all right, for some patients. And obviously some patients, unfortunately, if you have complications, like any other treatment, as you know, there are risk of complications, then you'd need an admission where you'll be looked after by one of the net consultants. Sometimes there'll be radiation precaution that you might be still radioactive, and sometimes we need to involve other specialty like cardiologist or surgeon, etc. I just would like to show you the phases we went through with the PRRT service in Dublin. So initially, before the official launch in March this year, we started in September our first MDT, and we managed to deliver 9 treatments until March as an early phase, just to make sure everything is okay before we officially launch and treat more patients. When we started then in March officially, we started 1 treatment per week until June. Then from June, we are treating 2 patients per week, and we are looking into expansion. Just 2 weeks ago, as a trial, we treated 3 patients as we started to quickly be fully booked for 2 treatments per week. Just a little bit about the MDT. So who attend our PRRT MDT is the radiologist, the net consultant, and including our team in Dublin and Greg and Derek, the PRRT nurses and medical physics to make a decision whether PRRT is the right treatment for you, whether is it the right time to give you PRRT now. And this is very important, because you don't want to give PRRT too early, because you might have complication unnecessarily, and you don't want to give PRRT too late, because you might become so unwell and it will not be possible then to give PRRT. So it's always important to decide about the time, all right? So this is what we do at the meeting. We do this every first or third Friday each month. If there is 5th Friday, from 8:30 at 9, just after the net MDT. We discuss around 3 cases in you, 2 cases review each MDT. And obviously, there's a lot of coordination behind that. We have weekly coordination meeting to go through all patients before discussing them at the MDT. This is just to show you our data as of 15th of October. 22 patients have been having treatment in Dublin. We deliver 51 treatment cycles. This is saving 51 trips abroad. So I think that this is a decent number. I'm not sure how many of you in the room had treatment so far. See some faces. That's very good. This is just show you the MDT decision. So it's not always, PRRT is not always the right choice for you. There are sometimes other treatment that might be better for you. So as you see here, the big green here is when of all patients discussed, 41% may eventually had PRRT. Some patients, we discuss them, but they become unwell. For example, they have other issue like a heart issue or a cardiac issue, which could be related to their tumor. So then we couldn't deliver the treatment. And sometimes we decide that PRRT is not the right treatment for you. And this is sometimes it is the right treatment for it, just we have to wait maybe a little bit more for the tumor to grow a little bit further before delivering the treatment, right? There are some limitations. We are trying to recruit more staff in terms of admin, data manager. So it's a lot. It's not only the clinical staff. Also, we are looking into recruiting more medical physicists and nurses. We are. I don't talk about this, but Greg mentioned the grades of the tumor. So we are limited by license. So PRRT is not licensed for all grades of treatment, but the license is going to be expanded. We are hoping to get this approved by end of next year. And sometime we manage to get funding from the hospital for treatment that for grades of the tumor outside license. Obviously, if we think at the MDT, this is the right treatment for you. We are looking also to get more medical admission rooms so we could deliver more treatment. And eventually, when we have all of this, we could have more MDT slots. And also, we'll look into delivering PRRT as a day admission, especially if you live near by the hospital, if your tumor is not hormonal, is not functional, if you had already your first cycle without any complication. So might try to set up a treatment where you just come to the hospital, get the treatment, and go back home in the same day. As I mentioned in my first slide, we are looking into getting involved patients more into research and clinical trials. This is to contribute more to the future patients to make treatments for NETs better in the future, and also for clinical trial to give the options for investigational treatment to the Irish patients. This is just to show you the PRRT team. A lot of them are not here with us today. These are the radiologists. Some of you had the treatment. It's Nicola and Mathilde. This is Anno and Hilary you met. And this is Jerry, most of you know, who's not with us today, who's the admin looking after the NEST service in general. Jenny and Amy are the MDT coordinator. They coordinate the MTT. They make sure all the scans, if you have your scans done elsewhere, to be uploaded, etc. There's a lot of work. And these are our medical physicists. So it's Anne and Neve, who look after you from the medical physics side when you come for treatment. Thank you so much.
So thank you, Hussein, for that. And it's amazing that we now have PRRT in Ireland, and you know, it's just shows how much everything has come on in the years that, as Hussein said, back in 2009 when Donal O'Shea started looking or seeing NET patients. And like, we shouldn't forget as well that Tommie Gorman, which has left a huge void in our organisation and for us as a community. But it was Tommie that I think and Donal who sat down together back around 2007 to start talking about trying to get a NET service for patients. And Donal's going to talk to us in a moment about Tommie. But I also, just about PRRT, there is, as Net Patient Network, there's a lot of activities going on. And one of the things is I'm involved in Spark Europe, which is a European organisation to promote PRRT. And there's a survey that we've just developed, which we'll send out by email through Facebook and on our website. I'd encourage anybody who's had a PRRT, whether it be in Ireland or abroad, to please fill it out. It'll help to get our information, because PRRT is great it's here in Ireland, but still so many countries that it's not available in. And Spark Europe's remit is to try to push it out across Europe. So that information will come to you. Please do fill in the survey. I want to thank the pharma companies for supporting us today. Ipsen and Novartis have provided funding to enable us to have our dinner last night and to hold this event. All of our clinicians and nurses, thank you for coming along. They get nothing for coming here, so really appreciate them giving their time. It's a Saturday, it's a weekend, and I'm sure there's other things you could be doing, but thank you so much for being here. The Irish Cancer Society are here as well, and they have a stand in the next room, and they're open to you coming up and talking to them and chatting to them about anything and everything. But I want to highlight that there is a booklet now that has been developed. It's been in the pipeworks for the last 2 years, I think, but it's finally here. It's a really comprehensive and excellent booklet on neuroendocrine tumours. There's, I believe, 100 copies here today, so at the stand you can pick one up. And this will be in all the daffodil centres around the country, I think within a week to two, which is really fantastic. And thanks to them for doing that. And it was a big journey, and I think Hussein as well was a big involvement in that and getting that done. So that's a really a great leap forward. So our next segment, and before our coffee break, is really, we want to remember Tommie. Tommie was instrumental in, I think, in everything that's happened in NETs in Ireland. Like way back when he spoke with Donal, and between them they talked about setting up a centre. And then Tommie has been at the core of pushing everything, and he's been he's such a loss to us all. It's really difficult and hard to comprehend he's not here anymore. He loved this gathering, he loved being here. He always talked to us, and I think Tommie's speciality was being able to talk to us one-on-one, and he was a friend to all of us, and he always knew the right time to contact us, to say the right things. He gave us such support and such hope, and I know we all saw him on TV, and it gave us that lift to say, we can get and cope with this, and so we really miss him. His wife Ciara and daughter Moya is here, and thank you for coming today. So we're going to just play a short little video that we did, just a few snippets of Tommie over the years. And then I'm going to invite Donal O'Shea to come up and talk to us about Tommie and what his engagement was and how he found Tommie to be. So, thank you. And I should also say thanks to Justin, who's sitting in behind here trying to get all the technology working. And that has been played. We seem to have a problem with the video, so maybe Donal, if you would mind, come up and talking to us.
So I rarely stand up without thinking about what I'm going to say. Right? I usually think about and have it all well planned. We all grieve differently. So when Tommie died, I was shocked. Hands up in the room here who loved Tommie Gorman. Right? We all loved Tommie Gorman. And there are very few, we have limited words in English for love, right? So we love chocolate, I love wine gums. I loved Tommie Gorman. I went into ICU the day before he died. I phoned Dermot. I said, he'll be grand. He was dying. I should have known that. But he was indestructible. He was here for all of us. And I was flicking back through the text messages that I had from him over the years. Some of them about obesity, some of them about NET, some of them about Sligo Rovers. So, you know, he is in the room. He's here. We all impact on each other. And his role in the development of services for neuroendocrine tumours has been massive. The idea, I mean, just looking at Hussein's presentation about, you know, PRRT and 500 patients becoming 1,000 patients, and PRRT for how many? 20 this year? Yeah, 51 treatments. Like, I mean, Tommie would be so happy about that, and I like to think he is so happy about that. But we all grieve differently. So I did not attend the funeral. I did not post on rip.ie because I had no words. And when Mark asked me to say, would I talk today? I said, I'm actually pleased he's asked me to say a few words because I haven't been able to articulate the loss. So this is my first time speaking about Tommie since he died. And I would like to apologise to his family for that, but we all grieve differently. And we don't always grieve well or positively. Tommie's impact went way beyond NETs, actually. I mean, like, his guidance of me over the years when I was banging my head against the wall on the obesity front, his shepherding of what I should do next was instrumental in where we are now with obesity in Ireland, which is in an incredibly positive space. So the World Health Organization are coming here in January with 4 other countries to showcase what Ireland is doing in the obesity space. And Tommie shaped that from his time in Europe, from his time in the North, all those Good Friday agreements. I mean, he nearly negotiated the Good Friday agreement. So he has had an incredible legacy. And I remember at his book launch in Trinity, I don't know who it was at that book launch in Trinity, but you know, you had every single political party leader there. It was amazing, and they were all delighted to be there. So when he set about establishing a neuroendocrine tumour service in Ireland, he just brought all those skills with ease, and we have what we have now because of Tommie. And he would want this to be a positive event, a positive day, a happy day, a great day. And it is all of those things. It needs to be all of those things. And we need to feel the sense of loss. We need to own it, express it, but be positive and be happy. Because where we are, for a rare tumour and a rare disease, you know, we're very lucky that we had a Tommie to drive this, because there is a European Rare Network, ERN it's called, and it's trying to get services for rare diseases established in each country, and it's looking to kind of the next 10, 15, 20 years to get it established. This is one of the rarest, and we're top of the class in terms of the access to services that we have. Not perfect, we have to keep improving. As Hussein has outlined and as Mark outlined, we have to keep improving and working on it. And you have a feeling of Tommie kind of over your shoulder saying, we got to bounce today, or you know, the messages were always positive. So Tommie was a kind of a crutch for the patients, yourselves, and he was a crutch for the doctors, nurses running the services. He helped on both sides equally. His absolute joy when the patient walked into Cork, the hotel in Cork, who had just been diagnosed with a NET, and like 2 days later she walked into the back of a NET patient network, and she thought it was common. And his joy at being able to talk to her and explain, yeah, there is a way forward, and it will be fine, and you have a family around you. And I think that's, for decades now, I've talked about your work family and your family, and Tommie was a huge part of this family, and he is gone. We owe it to him to continue positively and happily to, you know, move forward, do things better, and you know, I think his influence is as real today as it was a year ago, as it was 2 years ago. And when I read that, you know, Sligo Rovers have just got 16.2 million to develop a new stand, I go, Tommie, he's not around, but that has just happened. So I think he is still working his influence. I like to think he's working his influence. We miss him in the NET service. As clinicians, I don't think we miss him as much as you, fellow patients, miss him. And I don't think we miss him as much as his wife and daughter, who are sitting here today. But we all loved him, and we all still love him. So I hope the video will work. It doesn't matter, but if it does, Tommie liked a bit of screen time, you know? So I think he'd like a bit of screen time if we can get it. Thank you, Mark, for asking me to say a few words, because up until now I had not spoken. And because I felt there were no words. And I still kind of feel that way. But this has been helpful for me. And we all need to go through the process. So thank you very much.
So thanks to Donal for that, very emotional message about Tommie, and we all feel his loss so much. I think the video, I don't know if we're going to manage it. It's some technology problems, and if we don't get it up to show you after the break, we'll put it up on our website and let you have a look at it. And I think what the video was trying to show as well, that back in the 90s when Tommie was diagnosed, he was always advocating and pushing for patient rights, and patients needed to be able to get the best service. And at the start it was abroad, and then he worked with Donal, and they got a centre going in Ireland, and then it's progressed to the NET Centre of Excellence, the appointment of Dermot O'Toole as the national lead for NETs. And by the way, Dermot has really sincerely apologised for not being able to be with us today. He had a small accident and he couldn't travel. It's the first time he's missed this event since we've been doing it since 2013. And he wishes us all the best and sends his regards to everybody. But as the years have gone on and the centre has developed, the Centre of Excellence with Galway and with Cork, there's such an amount of expertise now in Ireland, and we saw a flavouring of that with the presentations. And there's so much knowledge on radiology and pathology, the endocrinology and and oncology and all of that now. There's a massive amount of information and knowledge there behind it all that we're all benefiting from. And PRRT is the latest thing to come in. We've got gallium scanning a few years ago. And, Tommie has been at the centre of pushing for all of those things, that we get the best treatment we can in Ireland. And what the video will finish with is Tommie acknowledging that, how much things have improved and how much, still more to be done, but how much we've developed and what we have now. So I'm going to say we're going to have a break for tea and coffee. When you come back, we'll have question and answer session with our clinicians, and ask your questions, and hopefully you've enjoyed up to now and enjoyed the second half of the event. Thank you.